or do you look at health systems at the universal health coverage measure? And the resolution last November at the UN Assembly was very clear about about addressing the concern that universal health coverage would sort of give a little to everybody, but would leave out vulnerable and those most in need. So let me get folks to weigh in on how do you set priorities and protect the neglected and vulnerable in the context of also trying to extend basic services to everybody. Anybody want to put the first? Gary, I'm gonna let you rest for a minute. Bobby, you want to get the first?
Yeah. I think we agree that we need to really move from isolation, from vertical and multi goal for health, and we completely agree that universal access coverage is a good goal, but we have some concern about the universal access coverage. The first thing that we want to highlight is the universal access coverage need to take in consideration the unfinished goal for the current MDG. It is the first thing. The second thing is the universal access coverage need also to take in consideration the issue of quality. It is not just an issue of number of people reached, but it is also the quality of services that those people are accessing. It is really important. The second thing that also we need to really address when we talk about the universal access coverage, it is community, it is health system as strengthening. Sometimes we have the tendency to think that universal access coverage is just a medical issue. Yes, it is a medical issue. We need to address the health system strengthening, but health strengthening with a good community strengthening. It is really important as a community perspective. The second thing that also we need to take in consideration when we talk about the universal access coverage is the participation. It is really important, the participation of all the stakeholders at community level, at national level, all the need of the most risk at population, the most poor population need to take in consideration in this universal access coverage. We need to avoid having a double system, a system who is really performing well with rich people and a very poor health system for poor people. I think if we don't take in consideration all this the dimension, we think that we will not meet the goal of the universal access coverage. But we agree on the single goal.
Okay, Jeff, you want to get?
Yeah, I absolutely agree on the point about quality of the universal healthcare that Barbara just made. But the other thing I think is important is if you take our job, in immunisation, of course, what do you want? You want all kids everywhere to be immunised, right? You want to hit all of them. You want that universality. But how you do it is so fundamentally important, because without an approach that particularly targets the vulnerable, particularly targets the poorest, the rural, the ones whose mothers are least educated, that's the evidence. Without that approach, you introduce a new vaccine, and who gets it first? The rich families living in the city with the educated mothers. Yeah? Rich kids living in cities with educated mothers. That's the evidence. So we really have to approach the way that you approach the universal goal has to be through some sort of progressive universalism. It's been shown in some countries. If you look at the way Mexico and Brazil have introduced new vaccines, with particularly targeting first the most vulnerable communities, the most remote, the poorest communities, you will get to a much greater level of equality. If you just go blandly into let's give it to everyone, it's going to create inequity in the first instance.
Okay, Gary, short, and then I want to open it up to folks.
I'm always short. That's been my whole life. I had the opportunity to be at the third of the high-level meetings on the post-2015 health and development goals in Gaborone, and there was quite a bit of discussion, as you might expect, about universal health coverage. And I'm going to be very blunt on my opinion on it. It's a wonderful idea. It's a dream. The only way that dream becomes reality is if there's disproportionate focus on funding for prevention, which generally doesn't happen in any country. The only countries that have figured out how to do universal health coverage and not make it completely unaffordable are very wealthy countries, and some of them don't do it particularly well either. The costs associated with extending health care access to a full population, I believe, are not sustainable without substantial reduction in the net demand that can only be accomplished through prevention. Even here in this very wealthy country, the goal of universal coverage has not been achieved, also for political reasons. But the only way this country can afford it is if we come up with a much, much more robust prevention system. And if you think about treatment for non-communicable diseases in the countries we're speaking about here, you've got to prevent them in the first place to be able to deal with it.
I'm going to hold back. I'm going to hold back. I could say a lot on that one, but okay. What I want to do actually is to switch up here a little bit. We have a guest that was going to be making some closing comments, but she's such a wonderful commentator. I'm going to see if I can get Awa. Can you join us up here for the open question and answer, and then we'll let you make some when we get to the closing comments. The Honorable Minister of Health from Senegal.
That was just a confusion.
I know. I know. If I was a Minister of Health, I couldn't sit here and listen to all these things be said without weighing in. And I'm guessing that you're feeling the same way. So just be comfortable. So Dr. Kosek was at UNAIDS during the beginning of that, from '96 to 2001, and then got pulled off to be Minister of Health. Came back and ran was executive director for rollback malaria, and then was called back again to Senegal as Minister of Health. And I just want to point out that imagine the impossible and then make it happen. And for those of us who were in the debates in '99 and 2000, when AIDS had become a chronic disease in Europe and North America, with people living almost as long as they would have on treatment as they would have if they never had the AIDS virus. In Africa, it's a death sentence. And if you had described to most people in the global health community in January 2000 what actually existed in January 2010, they would have said, impossible. Not in the world I know. So that's my short answer to Gary's. It can't happen. Sorry, because there are actually more than there are actually a number of low and middle income countries that have made it happen. But now we want to open it up. Let's try to ask short questions and get short answers. It's a wonderful panel, and we really want to try to make the most of the time. And we know people have other commitments, so it's open for observations, comments. Yeah, and do we have somebody? Oh, well, then I'll use this. If you could pass that. Okay. They weren't planning for me to just hop up here.
Thank you very much. It was a wonderful and very rich discussion. And my name is Marielle Hart. I work for the International HIV/AIDS Alliance. I'm based in Washington, D.C. I work very closely both in Action for Global Health and the Global Health Council. And I'm very, very excited about this, hopefully, transatlantic dialogue and increased dialogue with the South as well on these really important issues. I just wanted to make an observation and maybe also get your views on the whole discussion, I think, around goals and targets is at this stage might not be the most useful way forward. I mean, we all agree that we need a single health goal, I think, a health goal that actually delivers on improved health outcomes for all. So also in the discussion around universal health coverage, I think what we really need to talk about is what are the kind of targets we need to implement it at the country level, taking into account that it will look very, very different in each country. So while we need a universal health goal in the post-2015 framework, the reality of how to implement universal health coverage at the country level will be very, very different in each country. And
Okay.
what are the targets we need to talk about in order to make sure that it is meeting the needs of the most marginalized populations? What are the key principles that need to be in place?
Okay, so principles for setting targets at national level. And let's get maybe 3 comments or questions. I also want to hear Dr. Kolsek's comment at some point about some of the issues around roles of different sectors. But other comments? Yeah.
Hi, Steve Lewis, a member of Results, and Results is part of Action for Global Health. I'd like to ask Baba, but maybe any of the panel. The UK gave their contribution today to Global Fund. They publicised a pledge of up to £1 billion over 3 years. And at first we thought, wow, this is terrific. And the USA, of course, have made their pledge as well. But both countries have said they will only give a maximum, a percentage, and it depends on other countries. So you were talking a lot about financing. Do you see a trend here that the bigger countries are stepping back and trying to share responsibility for global aid with other countries that maybe are perceived to be not pulling their weight?
Okay, so financing question, then one from the back here. Yep.
Yes, good afternoon. I'm Maggie Spierlu. I'm Public Health Cluster Leader at the World Bank. How do you see the transformational role of ministries of health with the changing global landscape, not only in health, but also rapid urbanization, globalization, climate change, etc., to name a few? And how do we equip ministers of health to play this new role?
Okay. So national targets, fair funding, and the right people stepping up, and the role of ministries of health. Maybe let's take them one at a time. With just not everybody needs to weigh in on everything. So let's go in reverse order. Changing roles of ministries of health. How do we see that? Do you want to observe on that?
Okay, just Maris, thank you for this wonderful question. I just want to say that, in fact, Ministry of Health, I think it has been always that, are not Minister of Medicine. And this will be more and more important. And the profile will be to ensure that public health is not only looking at diseases, but looking at financing, looking at all the other side, and also a lot of capacity of partnership. Because one minister and one sector cannot really resolve the issue of health. And this is for me something to show that this openness needs to be one of the main characteristics of Minister of Health. You need to work with education. You need to work with agriculture because of nutrition. You need to work with finance, etc. And if you don't do that, you are not succeeding. And this is why, for me, the profile is more linked to the fact that maybe it was what we had to do before, but now it is more clear, I think, for all the issue. You need also to be very linked to social sector. So this is, for me, very important. I wanted just to, maybe I continue, just to look at this issue of maybe the donors countries with their pledges. It seems to me that this has always also been there. Since the beginning, it was important to know that, for example, the US will give this percentage to the Global Fund and the others will give the rest. So it is not that a country is would like to do all. All the countries would like to see the others helping them. And if it is not done like this, at the end of the day, the country is the money is coming from the people of these countries, and they will say, why we are the only one putting money in global health? Where are the other rich countries? Donc this is for all the donors countries the same question every year. And it has been there also for the Global Fund. I remember that the US was always saying what the others will put. If they put this, we increase. If they don't put, we stay at this level. So this is for me something. The last point is linked to the third question on
indicators.
And local and country indicators. Of course, universal coverage, as Baba was saying before, it is important not to look only at the demand, but also at the offer. And when we look at universal health coverage, also we need to ensure that it is not only access to care, but also health promotion, prevention, and looking at disabilities. All these are part of universal health coverage. And the indicators need to be at global level broad for the countries to be able also to adapt it or to add some which is very local. But it is always that countries themselves need to adapt the global goals. If they don't do that, they don't own it, and at the end of the day, they don't have really results. For me, it will be important to define first what is universal health coverage, and I have heard some of the things for me are not only care, but also we need to have broad global goals to be adapted at the reality and the local condition of different countries.
I'm going to focus primarily on the third question, and I don't envy ministers of health their job. I think they have a incredible set of challenges that they face, and the good news, I suppose, is that we have incredible interest among students, undergraduate and graduate students from my institution certainly, but worldwide, who are interested in working on global health issues. One of the objectives or the challenges, I think, facing governments and ministries of health in particular is in meeting this agenda for prevention. I agree very much with you that prevention is important and health promotion. They're going to need to take on some very powerful actors, such as very large businesses that are selling, for example, tobacco or unhealthy foods or mining or the mining sector. There are a number of industries that can have a negative impact on health. And it is the job of national governments to regulate industries in order to protect the health of their own people. This can be, of course, very difficult in poorly resourced countries. But it is one of the examples of the types of roles that ministries of health need to, I think, be ready and willing to take on with the rising burden of non-communicable diseases. The second point I wanted to make is that certainly financing is very important, and the role of various countries in contributing to international funds is critical. But I think it's important to not lose sight of the importance of global rules as well. And if we think back on the HIV example that Jana mentioned, one of the reasons why we have over 9 million people on treatment today is that they are on generic antiretroviral drugs, and they were able to access generic drugs because of flexibilities that people fought to build into the intellectual property regime. And that was a shift in global rules that was necessary in order to enable increased access to treatment. I would add that it was, in fact, marginalized populations who organized themselves politically to push for those changes in rules. It was IDUs, MSM, CSWs, you know all the acronyms. It was not necessarily the power brokers who were responsible for pushing for those changes in rules. Ministers of health today face the same problems, the same challenges, if not worse. You have trade agreements, you have investment agreements, for example, that tie the hands of governments to regulate tobacco companies operating in their territory. There are a number of big cases at the World Trade Organization, for example, as well as in investment tribunals that are challenging national tobacco control policies. So ministers of health, who used to be thought of as doctors, need to be able to engage not only with other sectors in their own countries, but with these rulemaking processes that are happening at the global level. And certainly that has not been the classic training provided to many staff working in ministries of health. So the last point I'll make is that the training and education of future global health professionals is really critical. And for those of you who've not yet heard, I'm happy to announce that the Harvard School of Public Health is launching a new doctorate called the DRPH, precisely to try to train future ministers of health to deal with this very, very broad and complex set of challenges that go far beyond what ministers of health used to have to deal with before.
Okay, so that answers your minister question. Is there maybe we got time for one more really burning question, and then I want to get offer each of the panelists their vision. And you were going to get 2 wishes, but I'm actually only going to give you one to keep us on, and then we'll hear again from Dr. Kolsak. So I'm not going to make the choice that 2 people. Who's got the microphone? I'm afraid. Okay.
I don't know how burning might my question be, but I wanted to make a point about something that Gary mentioned on the involvement of social behavior sciences into the changes that are required. Just do we realize that reaching this kind of change through social behavior will be almost as costly as providing social coverage? I just was scribbling a couple of examples. Early child marriage is common in almost a quarter of the world, and is supported by a network of confusion between culture and religion that people really feels entitled to. I was noting, like, also related to misbeliefs, such as in Angola, there is a belief that having sex with 50 virgins will cure you from HIV, and it's a very serious health problem.
Okay,
so
so
even Uganda's Ministry of Health policy on not tackling alcoholism among the rural populations.
So changing human behavior is part of the prevention agenda. Possible or impossible?
Well, when I say something's a dream, it doesn't mean I don't think it can become a reality, by the way. I think to make a dream a reality, you have to have practical means of achieving it. In response to this question, I would say, irrespective of whether there would be a similar investment to change social norms to address these behaviors relative to treating people who may be victims of these behaviors, there's a human component to this. I would invest 1,000 times more to protect girls from child marriage, to protect vulnerable children. I would invest 1,000 times more to protect vulnerable populations. At that point, I don't care about the investment anymore. I happen to think the investment will pay itself off and have a much better return than spending the rest of eternity treating the outcomes of negative human behavior.
Well, that's clear. You're now even.
All right.
With the UHC one. Thank you. Let's start at the end. If each one short wish for. Let's just go straight to post 2015. We're going to try to ask people what they wanted between now and. But let's at the end of in 2015. But one short wish from each of you on what you want in the 2015 agenda, post 2015 agenda. Suri?
I'll be very brief. Research.
10 words. Research. Okay, perfect. Well said. Gary?
You're going to be angry with me again, because I'm going to give you 2 answers. Okay.
Don't listen to the second.
It takes 2 seconds. There's 100,000 women who have to be dying less each year to achieve MDG 5. There are football stadiums that seat 100,000 people. It's not a lot of people. There's a lot of investment. My short-term wish is we almost go one by one on maternal mortality. We achieve that MDG. It's shameful. That's the one that's had the least, the biggest probability of being missed when the denominator is the smallest. Long-term, I've already talked about vulnerable populations. That's where I would put the focus.
Okay. Okay, Jeff?
Yeah, invest in data. We say we've saved 5 million lives. We don't know how many kids actually died last year. I heard Margaret Chan say yesterday that it was 86 out of 194 WHO member states have no statistics of cause of death. We need to invest in the data. If we don't get the data, we won't get the evidence, we won't get the donor money.
Baba?
No one will be left behind in the post-MDG trend.
Okay. Dr. Marie-Paul?
Well, I hope that between now and 2015, there's a way to socialize UHC so that everybody gets it, that it's from promotion to palliation, and that it is there for everything, including mother and child death, HIV, TB, and NCDs.
Okay. So then what I want to do is invite Dr. Kolsek to come up to share any final words, and then Lola Dari will close us, right?
Okay. I would like first of all to say that I was not planning to come. My flight was planning to come in this afternoon, but we came earlier, and I just forced to come and be with you, because for me it's an opportunity to see this Global Health Council with the Global South together, and also for the European NGOs to be part of the same discussion and to try to ensure that it is not, somebody say nobody left. If you do that, you will be sure that you will have to really put everybody together and have all the wishes for all the world, and not only for one South or one global. It will be everybody. So I am very happy to see that this happened today. The second point is that all the panelists has been, and the keynote speaker has been fantastic, because we would like to stay more, I am sure. If we had time, it will be a discussion of 2 more hours, but we have to stop now. And I wanted to take all these points and try to put it, what is the impact of what you said in Senegal? But I have no time to do that. But just to say a few words, DNDi and the research, having a malaria combination product in Africa has changed also a lot of things in Africa. The private sector has done a lot. As Gumbala was saying, maybe we need to ensure that also the private sector at country level is also doing its own job of social responsibility. We are trying in Senegal to do that, and in October, end of October, I have a big meeting with the private sector in Senegal to see what they can do more. For Gavi and for immunization, today Senegal has been put as a sort of example in the decrease of child mortality, but this is a lot due to immunization in this country with more than 80% of coverage, and this has a real impact on child mortality, but also malaria successes, etc. But it is important to have vaccination for children. The community also, the NGOs, has been putting a lot of pressure on government, and I think that it is very important. And I want to use the example of not only HIV/AIDS, but also tobacco control. Today in Senegal, they have put a lot of pressure on if the donors are really stepping down, what we will do with all the people who are under treatment on antiretrovirals. Senegal needs to take the lead and try to do something, and try to do that before the money will decrease. And this is something they are pushing a lot, and this helps us as Minister of Health to also have maybe a more success with the Minister of Finance and with the head of state. And this is very important to have NGOs and the civil society fighting at country level. But also for tobacco control and the new law on tobacco control in Senegal, this has gone through the cabinet now, going to parliament, and we would like to put a tax on tobacco to ensure that this money will come for health. The last point is really universal health coverage. This is also something we launched just last Friday, and we know it will be difficult, but we think that for equity reason, we need to do that. And this is for us one of the ways to ensure that the vulnerable and all those who are not looking at are taken into account. So I would like to thank all the participants. Thank you also for inviting me, and it was a pleasure for me to be here and to listen to you. And I am sure that all the people who are here will go with really a lot of energy and a wish to do more in the future, and to do that in a more harmonized way and with a lot of solidarity. Thank you.
The best boss I ever had was Dr. Gro Harlem Brundtland, the former Prime Minister of Norway, who became head of WHO. And she said that her father, who was a politician, taught her two things. Never leave things on your desk at the end of the day because there are people out there waiting for your decisions. And treat everyone as an ally. And I think I see that in Dr. Kolsek, just recognizing that lots of different people can contribute. It's now a great pleasure to hand over the mic to Dr. Alola Dare, a community physician and epidemiologist who wears two hats. She's the CEO of the Center for Health Services Training, Research, and Development, and she is also the convener of Global Health South, who's our other co-sponsor. So, Lola, over to you.
Thank you. I don't know if I'm supposed to say thank you to everybody for coming, but I think there's so much appreciation to express to everybody here. But it was actually very interesting to listen to everybody talk about issues that affect all of us, whether North or South. When we were in Gaborone, I said to the community there that I used to think that malaria was the most important thing on earth. And I came away from Gaborone learning that people have cervical cancer, people have chronic diseases, even the North is struggling to deliver healthcare to its people. It's really a global community when you talk about health. It's no longer a North or a Southern issue. It's really something that we in the global community should be engaged in. I also learned in Botswana that something has changed. It became very real to me that something has changed. Something has changed because civil society in the South were in Botswana. We pushed and we were heard. We were not only heard, things changed because the global community is actually ready to listen to us, and we can change things. I have many friends in this audience, and I keep on pushing, and I will keep on pushing until we reach the last person, and we are also part of the global discussion. I've also learned that there are stronger and informed voices from the South, and these voices need to resonate. Their context and their reality needs to be at the global level. We can speak for ourselves. Baba, I'm very proud to be here with you because we can speak on behalf of our communities and we can speak for ourselves. We can raise those issues, we can bring our context to the global discussion. In fact, we have a moral responsibility to do so. The door is open for us to do so. Our ministers are ready to support us to do so, and our heads of states are ready to support us to do so. We also are learning that there's going to be a dynamic change in global health. It's not going to be about aid. It's going to be about domestic resources. And those domestic resources need to be led and directed to our own priorities. And so when a global target is set, will it always reflect our priorities? Not all the time. But when domestic resources are going to be expended, it has to be expended against our own priorities and our own work. We also are learning that accountability is going to be important. Accountability is also going to go beyond being accountable and reporting, and is going to go to being held to account. A couple of ministers, heads of states, election processes are being informed in a different way in our countries, totally different way. It's not business as usual. So Global Health South seeks to influence that discussion, bringing to the global discussion what we are also discussing at the country level and seeing if it can change. Like Baba, I learned during the global discussions that while the global community is very focused on issues, goals, and targets, it's my issue, sexual and reproductive health, very important issue. We must protect adolescents. We must protect women. We must protect children. There are many issue groups at the global level who are actually speaking about these important issues, and we thank you all. But we have other issues you're not talking about. Partnerships are important. Governance is important. Leadership is important. Accountability is important. Process issues that we have learned at the MDGs that do not lend themselves necessarily to goals and targets are going to be important to us at country level. Why is Africa not achieving the MDG? Is it because we don't care? I doubt it. We care. Our governments care. Our ministers care. But they also need good partnership behavior at the country level. Partners who speak at the global level have to walk the talk in our countries. We need to hold them as accountable as our ministers at the country level. We don't have time. But I'm happy to present to you One Voice. One Voice seeks to recognize that north to south, we share the same goals and the same priorities of a healthy planet, a sustained planet, and well-being. We share the same goals of ensuring that our people are healthy. We have the same passion for making sure that no one is left behind, societies are transformed, people are healthy, they are able to afford healthcare, they're able to afford education. We all share the same priorities, but we nuance them differently. We nuance them based on local realities. One Voice seeks to bring that local realities to the global discussion. It seeks to influence the political discussions. Because honestly, when I was going to say these politicians, and I remember I shouldn't say that. When the politicians make the decisions, the process issues are going to be important to that decision. They're going to think, how much is it going to cost me? Can I afford it? If I can't afford it, then I'm going to drop it. Who's going to do this with me? Who's going to trade with me? There are so many things that are going to be negotiated in that political discussion that goes beyond what we've discussed. So One Voice seeks to influence that political discussion right from the country level. Work with our ministers, work with our heads of states, and also work with our northern partners to influence that global discussion. One Voice seeks to frame. It seeks to take the human rights discussion further and include human security. Human rights has given us a voice of policy, protection. It has given us a lot of individual responsibilities, individual rights. We need to move that to protecting all populations, including the vulnerable. We need to give them freedom to live far from fear, freedom to live without want, freedom to live in dignity, and the issue of well-being. We're going to be talking about multi-sector approaches. What does multi-sector approach mean? I don't think it means the Minister of Health becomes the Prime Minister. I don't think the Minister of Health is going to be able to be responsible for water. She's not going to be able to be responsible for sanitation. There's a minister that is responsible for that. So we in the health sector are going to learn to work differently. Not only Baba should be talking to other sectors. We in the health sector also need to work with other sectors. There's quite a number of things that we think of doing with One Voice. But the important thing is that we want to promote the unity in what we agree with, and yet be very sensitive to the things that must be different from continent to continent, country to country, region to region, because our priorities will be different and our issues will be different. We want to ensure that it's not all taken off by political discussions. The agreements we have continue to influence that discussion. One Voice is a North and South coalition. It seeks to spur community engagement and actively promote the engagement of Southern civil society and other global advocates in that political process. We have established 5 working groups, and we invite you to join those working groups. One working group on principles, and we are really focusing on this intersect between human security and human rights to provide both protection and empowerment, and to look at a framing implementation process for our outcomes. We've looked at a very interesting working group called universality. I would hesitate to join that debate on health coverage at this moment. But I think we need a continuing discussion on it. Is it universal health access? Is it universal health coverage? What does it mean to us? If it's universal health coverage and we say it's covering everything from disability, wow. We've got a tall order ahead of us. And if Africa has not achieved even these basic goals, can it provide everything for everyone at no cost to anyone? It's a continuing discussion. That work group will intersect with that discussion. We have a working group on process. In our consultations with civil society in Africa, partnership, leadership, accountability, and governance will matter. For accountability, we would like our northern partners to join us in holding partners to account at the country level. We need them to work better with our ministers, to do things better with our ministers, to ensure that aid is predictable and is aligned. There's so many things around partnerships that we're going to talk about. I was very excited to hear Mary Paul talk about a different WHO. What is that different WHO? We all don't want to talk about it, but we really need to face that. What's that different WHO? From the country level, we would like to come back to you through One Voice to say we have had consultations and discussions with WHO at the country level, and this is the kind of WHO we think that should be in global health. Who should lead global health? WHO? The Global Health Team in the Office of the UN Secretary General? These are process issues that affect the resources that you very kindly mobilize for us at the country level, at the global level. Vital statistics, data, and information systems. What we don't measure, we cannot be accountable for. I heard from Gracia Michelle that register the birth of a girl so that we will know that she's died. Many of our girls are dying because we don't even register them. So even what we're counting now is not what we know is that's occurring at the level, at the country level. Many of our boys are also out of school because they can't afford to go to school and they're selling wares on the road. They're out of school, young boys on the road. So we need to invest in vital systems. But we advocates at the country level need also to work with our governments to see what's that vital system and how are we going to invest in it. I welcome you all, please, to join us in One Voice. The announcement is out there. The registration is out there. You can register online, and you can register into a working group. And I really, really am excited to be working with the trio because it's the first time we can amplify north to south and south to north and still have one voice. Thank you.
Thank you, Lola. And one final comment. There are also refreshments out there next to the pamphlet on one. So help yourselves. Thank you.
Oh, okay. Well, those are two tailors I have to think very highly then of. You know, I'm working a lot with Wendy, and we're trying to get an announcement out this week, and it all depends on WHO at this point. Terrific. It's okay. Absolutely.
I understand you guys are doing quite a lot with Woodrow Wilson School.
Okay. All right. We should definitely talk, because I have ideas about taking a number of things to scale, but we've got to get this first model going, and we're right on the cusp of it. And I... Oh, thank you. Oh, thanks. Okay. Probably isn't, but I definitely want to meet, and I want to share with you things I've been discussing with Peter Singer and with Wendy, and we really have an opportunity to make a big change in a positive way. Exactly. All right, good. All right, thanks for reaching out to me. All right. Okay.
Caitlin, how are you? When I saw you in the elevator, I was like, I'm late. I'm supposed to be here. And it's 3 o'clock.
Yeah.
I was a bit distracted.
Yeah. Absolutely.
Hello, how are you?
Yep.
Lovely to see you.
Absolutely.
Yeah. You going well?
Just so that, sure. Yeah, we're right. I mean, we're just starting to tap into the potential there, in my opinion.
Well, yeah.
Okay, that'd be terrific.
Had the last couple of times.
Absolutely. Yeah, he's a good friend. I'm familiar with his role.
Thank you.
I'm so sad to see him going back to normal life, but absolutely.
I've always met other people to go. Written talking points, made arrangements.
Yes.
Do you have any other particular events yourself?
Yeah. Yep. I get down there usually once a month or once every other month. Let's plan to meet. And, Eric and I are good friends, so, yeah, I'd be happy to. Give me another excuse to visit him before he goes. I'm talking to him. Thank you. Thanks. Bye. Okay. Yep. Okay, so we have overlapping interests.
Okay, well, if I if I don't see you, I'm sure I'll see you this week. I'll see you tomorrow. But then that's great you coming. Really good. Perfect. Great. Thank you, Lola.
Sure. Yeah. And I would suggest my colleague also Rudy Pagade. She's the Vice President of Global Health. It's sort of my right-hand person. And she knows of JSI from work we've done years ago. Yeah, I'm still on the board, but it's the only affiliation I have that's relatively inactive, and I'm struggling with it. Yeah, Nave has some challenges too. Yeah.
Very good. Thanks for having us.
Thank you. Thanks.
Sure. Yeah. We've got a good facility.
Thank you. Oh, we should follow up.
Yeah.
That's I remember seeing you. So much it can be done.
Oh,
Sneaky under the radar.
exactly. South Africa.
Yeah, absolutely.
One of those places.
Thank you. Thanks so much.
Send me an email. Experience.
And you made some comment.
We'll find a way. You can get out here anytime.
Come on to mine. This is why we.
Okay. I mean,
I go then.
I was at American Cancer Society, but now I'm at.
Have you pick it up?
Yeah, I know, right?
the guy who, congratulations, by the way, it's impressive. The guy that was just here is the executive director. You know, I'm acting CEO. But drop me a note, and we'll see how we can connect, because we do have, you know, a lot of people in your circumstance, relative number, who come in and your credentials sound. My quick observation is your credentials are extremely strong. Right? Sure, yeah, we have the internship program.